So I'm going to talk about a fresh look at the kidneys. So I'd like to thank the organisers for inviting me to speak. These are my conflicts of interest. The only thing of note is that this talk was sponsored by Baxter, and the study I'm going to talk about was sponsored by Cheetah prior to them becoming part of the Baxter organisation. So what we have to ask ourselves is, what is successful fluid balance? This is a thing that the iFAD symposium, of course, obsessed with, quite rightly so. But if we consider our level 3 or ITU patients, what's successful fluid balance? Well, it's probably fluid balance whereby organ support and interventions are minimised. So reducing days of ventilatory support, the need for inotropic or pressure support, or in fact, reduction in acute kidney injury. Also, a reduction in length of stay and costs would be nice. I mean, that would be successful. And quality survival. I think that's the thing we should aim for in all our patients, not just to survive, but to survive with quality. Now, intravenous fluid is important, and these bell-shaped curves can be drawn in so many things in medicine. And this is the sweet spot where we want to hit the optimal volume, the optimal fluid balance of the patient. So too little can be associated with tissue hypoxia and hypoperfusion, and too much fluid can also be associated with organ fluid failure, particularly the kidneys. And so here, too little fluid, or acting as if there's too little fluid, is fairly characteristic of sepsis and shock. And volume overload, we know in patients with sepsis, is associated with an increased risk of mortality. So careful management of fluids, and the ERAS program has shown us that, can greatly enhance the patient's outcomes. Now, it's no radical surprise, right? I mean, this is a paper from 1992, so a long time ago. I was just a mere lad at that time. And this is a paper on improved outcome based on fluid management in critically ill patients using the pulmonary artery catheter. 101 patients were randomized to 2 fluid management strategies. One was based on a lung water calculation, one was based on wedge pressure or pulmonary artery occlusion pressure. And effectively, what it showed was a conservative measure of fluid prescription ended up with less days on mechanical ventilation and less days in intensive care. So put it to you that nearly 30 years ago, we knew the dangers of a positive fluid balance, and yet we're still having to go to lectures that tell us that, because as doctors, we seem loath to learn. So this might be the way forward, right? So this is our traditional medicine approach, and this is our personalized medicine approach. And of course, we can adapt that to volume. So this would be the traditional volume prescription. So when I was a surgical houseman, I was told quite regularly to prescribe 2 salty and 1 sweet to all the patients. So 2 litres of saline and a litre of dextrose. Whereas personalised therapy pointing at the patient is where we should aim. Now, when we give fluid, how can we assess a response? So if we look at unstable patients and they're responding to a bolus of intravenous fluid, it's guesswork, right? This is a meta-analysis looking at all sorts of studies assessing whether patients or people could assess volume status and response to intravenous fluids in unstable patients. And really, it's about a toss of a coin. So what we actually need is a tool by which we can assess fluid responsiveness. So one thing to do is the passive leg raise, which is now fairly well established. The alternative is to give a bolus challenge and look at trends in therapy. So this is a rather simplistic view of what might happen to your stroke volume index with fluid responsive patients showing this increase in SVI, whereas those non-responsive, or this flat part of the Sterling curve, you get no additional increase in stroke volume, And so you could argue, why might you be giving the fluid? Problem is, of course, that fluid responsiveness doesn't always equal fluid requirement. This is graphic describing the effect of PLR and volume infusion, and you can see here that the effects are somewhat similar. And there have been several meta-analyses recently that have shown that a passive leg raise can predict fluid responsiveness. So let's go on to the FRESH study then. This is a study that I was involved in, the fluid response evaluation in sepsis and hypertension and shock, a randomized clinical control trial, led by iFAD Douglas, who I've known for a long time. So the FRESH trial used 124 patients, 82-to-1 randomization, 83 in the treatment, 1 in the usual arm. And they were enrolled with patients with refractory septic shock who'd had less than 3 litres of administration. And this actually proved quite problematic because the study was taking place about the time the new sepsis guidelines came out, survival sepsis guidelines came out. And so everyone was given fluids fairly aggressively in the ambulance room and the ED. So trying to catch patients before they had 3 litres fluid was actually quite challenging. In these patients, passive leg raise was used to assess any additional resuscitation decisions, either fluids or increasing pressures, over the next 72 hours of care or ICU discharge, whichever happened first. And so the passive leg raise was used to guide either fluids or pressors. These are the hospitals involved, and I'm proud to say that the Royal Surrey was one of those and the only one not in the US. The demographics, as you can imagine, were no different between the intervention group and the usual group. And you can see the mean plasma lactates were approaching 4, so a relatively sick group. This was the treatment algorithm. So this was the clinical treatment algorithm here, integrated with the passive leg raise assessment. So a clinical decision had to be made to treat the patient with either fluids or vasoactive medicines. And that's because the patient had to have a MAP of less than 65, systolic of less than 90, or a blood pressure that was rapidly trending lower. Alternatively, it could be a low urine output or any other clinical indication to administer either a fluid bolus or pressors. And so the passive leg raise assessment was done. If there was a less than 10% change in stroke volume, then pressors were titrated up to give a MAP of 65. So non-fluid responsive pressors were given. This is the pressor dose, and then patients were observed or had another passive leg raise assessment. In those with more than 10% change in stroke volume, fluid bolus was given, half a litre, and then they were reassessed for MAP and SBP with persistent hypoperfusion of fluid bolus could be repeated. And then they would either have pressors or fluids depending on the response to a PLR. Norepinephrine was a pressor of choice. If the patient was unstable for a passive leg raise, then hemodynamic stability was obtained with vasopressors first. And if the patient remained unresponsive despite 2 to 3 rapid algorithm loops within the treatment arm, an echo was considered to assess RV and LV function. We also included all the intravenous piggybacks, so all the antibiotics, etc., were concentrated to give no more than a total of 80 cc's per hour. So the results, well, here's the primary endpoint. The primary endpoint was fluid balance. And you can see in the intervention group, there was significantly less fluid given. And this translated to a significantly less length of ICU stay. And so the 72-hour fluid balance was significantly less, on average just over 0.65 litres compared to 2 in the control group. We're approaching 1.5 litres less in the treatment group. But what about the kidneys? That's the bit that I've particularly focused on. Well, if we look at changes in serum creatinine, Not a great deal of change between intervention and the usual care. But look at this, significant reduction in renal replacement therapy from around 17% to 5%. So a 12% overall reduction in RRT. And it wouldn't surprise you to know that the indication for renal replacement therapy in most of these patients was volume overload. And in fact, when we look at the needs for RRT, most patients are started now for volume overload rather than the classic hyperkalemia or acidosis. So in the control group, despite the fact that more aggressive fluid removal was confirmed with RRT and diuretics, there was less fluid. I'm sorry, my computer's playing up a bit here, so it's obviously getting very excited with these results. So fluid balance was less in the treatment group with better outcomes. We also saw this translated to other secondary endpoints, including mechanical ventilation and ITU length of stay. So also discharge home was earlier. So from a patient's point of view, it was all good news. And all the endpoints effectively favoured the intervention arm. And what we can conclude from this is that passive leg raise in septic patients is safe. It certainly reduces fluid balance at 72 hours and the amount of fluid administered, and improves outcomes. Less mechanical ventilation, less renal replacement therapy, and earlier home. So from a relatively small study with a relatively easy to follow protocol, these are significant findings, I think. And the editorial in Chest also pointed this out and suggested the fact that we should be talking about fluid refractory patients rather than non-responsive. And so you can see this fluid refractory line here rather than talking about up here. And I think this reflects the true situation rather than the flat Starling curve. So what we don't want is that or that. Okay, we actually want Goldilocks and the Three Bears personalised treatment to each of our individual patients. And with that, I'd like to thank you for your attention. This is an excellent poem to finish off the session, and thank you very much for listening to me.